Thanks. Thank you, Karen. Also, so thank you to Francesca and Jessica for organising the sessions, Karen for the invitation to speak. So we just very briefly just to introduce myself. So I'm from Centre for Health Economics. I have a role now in one of the co-directors, and we have a slight reorganisation. I'm one of the co-directors of our global health economics programme. I don't actually personally have much involvement in NIHR projects as much, but we're looking to have some colleagues in the audience arena, Naomi and Summit, so please feel free to chip in the discussion. So I'm going to talk about three things. One, I'll talk briefly about one project that we engaged in, HVAC, which is maybe a bit of an example of how we'd like to work more fully with in NIHR. And then I'll focus on some thoughts on capacity strengthening, the approach and some reflections and then I'll just kind of chat with the full range of health and economics projects that we do that with your engagement through NIHR. So firstly, we are fortunate that we've been supported with partners in India, Brazil, South Africa, and Indonesia for an NIHR unit on health financing in challenging times, living in all kind. The acronym is HVAC. And actually, a number of us have just come from Johannesburg, where there's a full programme meeting for HVAC. And I guess if we were to outline a little bit the type of ideal health economics project that we as a group like to get involved in, it involves a bit of methods development and applications analysis with a purpose and potential to affect policy and make a difference ultimately. So we don't see a distinction sometimes. In meetings where it's been presented this trade-off between methods research and applied research. But we like to think of it as being really integrated. That's going to be applied questions and applied challenges through challenges to methods research. Sometimes show the boundaries of our current method, indicate directions in which they're developed. And then the application needs to come from methods development. So we see methods and applied research as really being integrated with one another. And this project, which has its aim to strengthen abilities of countries to adapt health financing policies and programmes and more equitable, sustainable progress towards UHC, is an example of that. It represents integration across methods research and applied research in response to policy challenges. And we've tried to structure the programme such that that integration is quite explicit across 4 policy areas for applied research. Also 4 things of localising resources, efficiency and equity resource allocation, access to left-behind groups, and governance intersectionality, with 4 areas for which we have existing, sometimes advanced health economics methods, but areas which we feel methods development can further progress in an integrated and responsive way to some of the policy things. So methods focus is around impact evaluation, quite experimental methods, like on equity analyses, on economic evaluation, and benefits package design, and on political economy analysis. So yeah, this is kind of, I think, an example of still it's in early days, but kind of something like an ideal type of health economics program. It involves close partnership with policymakers in both countries, have a focus on left-hand populations, and specifically focus on equity, but it leaves lots of scope for innovation as well in methods. We always try to ensure there's some sort of methods innovation, but some of the NIHR calls is quite limited in terms of our potential to demonstrate methods can be better advanced. So now I'll go on to focus on capability building. Focus particularly on capability building, some thoughts on that. And maybe just initially to reflect, so capability building, capability strengthening can take many forms and can focus on many types of individuals. Everyone, whatever the stage they are in career path, is always or should always be continuing to strengthen skills and abilities. So it's getting noticeable in the wide range of audiences. And I don't want here to focus so much on capability building for those who work explicitly on the research or academic stream, but maybe focus a little bit more on the place of research projects in the landscape of the work we're trying to affect. And before I focus on capability strengthening explicitly, I just want to kind of say something about where potentially we see its place. So I've heard sometimes researchers in part can roll their eyes about the requirement to contribute to capability strengthening. Not really, but there's a risk that's seen as a sunk cost and added burden. And it shouldn't be for any of us. I think we need to realise why it's important, instrumental to what we want to achieve. So all of us working in global health research, particularly, I guess, we're ultimately concerned with outcomes, population health, improving health, particularly those facing greatest challenges, greatest health economics, greatest challenges to improving their health. And for research projects to make a difference in the real world, I think we've got to see the role of research as ultimately affecting decision making of some form. Research can only make a difference if it affects decision making. Sometimes that decision making can be many, many years into the future, particularly looking at research product development, for instance, see difference, and also can be kind of certain steps at times. But for research to make a difference, it's got to work through decision making. So how does research work through decision making? Well, we, as a group, like to think of three interrelated strands. You need research, which is policy relevant or decision relevant of some form. We need to support and work on pathways for research to policy impact. And thirdly, we need to contribute to capacity strengthening. We need to contribute to capacity strengthening both in the production of research, but also in the ability to shape and use that research in decision making. So we're particularly interested as a group in supporting capacity strengthening interface of research production and use. And also we try to structure our contributions to capacity strengthening with a long-term vision. So sometimes the demands for capacity strengthening can relate directly to projects in the short term, but it's unclear how that builds into a longer-term pathway. So I find it useful to think about career pathways, and particularly key career pathways at the interface of research, production, and use. And as a community, we should be seeking to support people through continued development of skills and the possibility to utilise those skills right along the career pathway, because that's where we as health economists working with collaborators in policy decision space have our potential to make greatest contributions to what we really care about, which is improved health and improved health equity. And so this requires making contributions right across that career pathway from if we were to begin maybe already gotten degrees from contributing to an MSc study. Sometimes that can be policy people can taking some time out to develop skills to MSCs. I think structured distance learning programs have particular potential here to enable people to develop their skills whilst continuing to work through continued professional development, short courses, and for those who wish to pursue this and have the sense of their career goals through PhD studies. I would say from a UK perspective, rather than NIHR, sometimes that will be capacity strengthening provision, course provision in the UK. Sometimes, and hopefully increasingly, that will be strengthening training opportunities for people wherever they live, closest to their home country, so like universities in the global south. So to reach these goals of capacity strengthening, which is organised, is managed, contributes across the career pathway, it's long-term and doesn't begin and stop on a project-by-project basis. We need to really be organised and managed in terms of how we make our contributions, and these need to be multi-pronged. So just to give a number of examples of things that we seek to contribute to, and we hope to contribute to in the future. Sometimes this is supporting independent research, both in the UK and in countries in which we collaborate. Learning by doing is important in this respect, and mentorship that's strengthening. Sometimes short course provision has a really important role, also for policy audiences as well as researchers. Contributing to those that interface between research and policy networks, including capacity strengthening. Sometimes it's best organised regionally. In Europe, we contribute particularly to regional organisations, East Africa and South America, those two examples. Inputting into training curricula, for instance, MSCs. We're trying to support university partners in the global south in the design of their curriculum. Offering scholarships where this makes sense, and we've been looking at how universities supported our global health research program provision of scholarships, and importantly, finally, where possible, making materials publicly available and free, and reducing the barriers to access. Just to give an example of that, we support this website, globalhealtheconomics.org, which includes a real provisions in health economics training. Some of these are from our MSc residential programs, some short courses and webinars. But if you haven't accessed this website, I encourage you to do so. And just at the bottom on the current page of this website, we're fortunate that our Vice Chancellor gives 14 MSc studentships, which are provided from distance learning, so it's enabling people to remain in countries and home country jobs, but continue to build their skills through career path. That's our goal. We have, so I talked a little bit about the first project here, which is really fully health economics projects. We also have involvement in a number of other NIHR projects, many of which focus on particular clinical areas, and some opportunities to build on economics and develop methods in respect of
as you know, that's completely. Yes, yeah,
there's been actually a number of colleagues who really actively engaged in NIHR research as well.
Very much, Paul, and welcome to those of you who are joining us. So our second speaker is Tim Powell-Jackson from the London School of Medicine, and he is going to talk about an NIHR-funded health systems program with an emphasis on equitable partnerships.
Great, good morning. Thanks for coming to this session, and thanks very much for the invite. So I'm going to talk. I'm going to give some reflections on equitable partnerships within the context of a NIHR-funded project that I lead with Professor Victor Mopasa called Impress Malawi. And this stands for Innovative Management Practices to Enhance Hospital Quality and Save Lives in Malawi. And just to give a brief bit of context, we started during COVID, and we were also, in terms of the individuals involved, we were new to working with each other. So whilst the London School of Hygiene and Tropical Medicine and who has have had a long-standing relationship and partnership. Us as individuals were new to working with each other. Okay, so the aim of the project is to improve the quality of small and sick people care and ultimately reduce in-hospital mortality through the adoption of management practices and processes. And so, as I said, it's funded by NIHR through the Global Health Policy and Systems Research Commission call. So I think Ankara presented it was one of those specific tools that NIHR has. We're a 4-year project. We started in October 2020. And as I said, it's a partnership between the London School of Hygiene and Tropical Medicine and Cambridge University of Health Sciences, which is formerly known as College of Medicine, just in case the new name is it's not recognizable. And in terms of our collaborators, we work very closely with the Ministry of Health, the government of Malawi, and also a program called NEST 360, which is funded by, I think, 5 different external donors, which is more of an implementation project around sick and small newborn health. We're sort of very closely aligned with their work. And over the past year or so, we've also developed very close links with another NIHR funded project called HiQ, which is run and managed by Treasury Trust in Kenya. I think somewhat coincidentally, we are doing research on quite similar topics. So just to say why equitable partnerships are important. You know, at LSHM, where we do a lot of global health research, of course, we do research also on the NHS, but there is, I would say, you know, more than 50%, I imagine, your hand could tell us, of how much of our research is in global health. So partnerships are really the foundation of what we do. And building a healthy and mutually beneficial partnership is intrinsically concerns equity. And at the heart of equity is obviously principles around fairness and the distribution of resources according to needs. But for historical legacy reasons, power relations, imbalances and opportunities to get access to resources, maybe perceived hierarchies in the generation and use of knowledge, these are all potential reasons why partnerships might not be equitable. So there are lots of moments within a research project in which issues around equitable partnership might arise. And this shows a sort of chronology of the research project, starting from the left before the research project starts, all the way through to its completion, specific moments or points where issues might arise. I won't go through each of the boxes, but the different colors refer to the top pinky color refers to basically people management and governance. The green refers to research project activities themselves, and then the yellow is more about the contracting and sort of budgeting and financing aspects of the research project. And so I'm just going to give some reflections using that kind of structure of those three areas. And I guess these are somewhat personal reflections from the project structured around that framework. And I just want to call out a tool which has been developed at LSHM called EquiPar. This is designed to help researchers at LSHM develop equitable partnerships. It is available if you Google EquiPar LSHM. You'll find it. And actually, it's not just for people at LSHM. Anyone can provide comments, anyone can use it. And it's essentially a whole series of questions which basically encourage you to reflect. Okay, it doesn't provide answers. It gives you questions to make you think and reflect. Okay, so some reflections. So I think communication is key to an ethical partnership, and we've relied heavily on Zoom, as I'm sure everyone's workplace has changed into a Zoom or Teams dominant workplace. That's largely due to COVID. So we have weekly project team meetings. But I think, I don't think this is a temporary transition. And as we think about net zero and not flying as much, I think a lot of communication is going to have to be done remotely. But it does, it does change the whole dynamics of the partnership when it's done remotely. So I guess it also means that when you do travel and meet, that you make the best of those opportunities and treat it very strategically in terms of developing that partnership. I think it's particularly challenging when the partnership is new and you're doing it remotely. There is nothing like meeting people face to face, particularly when the partnership is new. The sort of balance of staffing arrangement is obviously key, and certainly with our project, that's basically decided at the proposal stage, because you write your proposal, you write your budget, and the staffing goes in at that stage. So that's a really key point, ensuring that the staffing balance is equitable with respect to what you're trying to achieve. Paul spoke about capacity strengthening. So in our project, right at the beginning, we developed a capacity strengthening plan. And a lot of that was around formal capacity strengthening. But I have to say, most of the capacity strengthening is done on the job while you work. And it does sort of, just going back to the communication thing, it is so much easier to do that when face to face, when with each other in the same room. So that challenge of what the future is going to look like in terms of being able to be face to face, there is a slight tension that happens. Now, a big strength of, well, I think the big strength in our project is that we work very closely between partners within teams. That sometimes does blur the sort of lines of accountability a bit. Who is accountable to who? We obviously work in our own institutions, we're accountable to people within our institutions, but when working very closely with the team, some of those lines of accountability can get blurred. I think it's very important to have good communication at sort of leadership level to, I guess, resolve any challenges around accountability. People who's asking who to do what. So I think that's very important in terms of resolving issues. And then opportunities to develop the relationship. We were, as I said, a new partnership in terms of the individuals. And I guess, self-reflecting, it has been a challenge not being able to travel and meet each other face to face in the initial sort of 18 months of the project. But having those opportunities, making the most of those opportunities is really important. So in terms of contribution to proposal development, that is a key stage, obviously, of any research project. That's where the major decisions are made, not just in what you're going to research, but how the budget is shared, etc., etc. And I think it just is really challenging when you're a new partnership in terms of getting really substantial contribution from everyone involved. Obviously, if you've got the partnership is long standing, getting that equal contributions to the proposal development is much more straightforward. We found a lot of the good aspects of our partnership that come through co-designing research tools, being in the same room and say for a week going through the very nitty-gritty of designing questionnaires, designing our methods, detailing what our analysis plans are going to be, not only for capacity strength, but also developing that. The ethical obligations of a research project can sometimes be tricky. I think in our case, it's been relatively straightforward. I think because of the long-standing relationship between the institutions, but the ethics boards of both our institutions, I think in very similar ways. And so that process has been straightforward. I guess it can sometimes be very complicated. You're putting your research study protocol through two ethics committees. One committee is saying one thing, and it may even contradict the ethics committee of the other, or raising completely different issues. So it is something I think to be very happy about and very aware of. I'd also to give lots of time in terms of getting those study protocols approved. And then on outputs, I think recognizing the contributions of everyone. I think in our case, it's been very useful to detail those planned outputs right from the beginning and assign responsibilities, even start talking about authorship very early on. Maybe not set in stone, but having those conversations early on is really important so that you don't get to the end of the project and tensions surface if you can't have those conversations early on. And then the final area is around contraction and resource management. So our budget, our split is around 2/3 goes to QHES and about 1/3 goes to Estage. And I think NIHR are very good at, I think, encouraging that kind of a split, I think. But that's, that's the balance of our budget. And I suspect if that balance had been different, we may not have been successful. I think it is a major thing that reviewers look at is that budget share, because it does reflect in many ways the equity of the partnership. Contractual arrangements can sometimes be tricky. I guess in our case, I think with the long-standing relationship between the institutions, that was relatively straightforward, and a lot of things were already in place, like due diligence and things like that. These kind of processes were already in place. They can take a long time if they're not in place. Data ownership is a very important issue. So in our project, QHES owns the primary data, and then we have an agreement for them to share the data with us. Interested to know other people's experiences. I guess historically, maybe LSHM might have owned the data within the contract, but I think the shift with the bank really needs to be that data is owned primarily by the institutions in the country, and then that data is as specified within the contract, is then shared to other institutions that are partnering. And my last point is around institutional rules and funder rules. And I guess it's a bit of a plea that I guess funder rules are flexible to recognize institutional systems and processes. QHES, formerly College of Medicine, has been around for many, many years, and they've developed internal systems, processes, for example, around accounting, that have been developed reflecting the reality of where they are. For example, the banking system is not particularly well developed, so they develop systems that sort of give response to that. And I think it's important that funders are as flexible as they can be within their constraints, recognizing the systems on the ground. Okay, well, thank you very much. I just like to acknowledge NIHR and also thank Catherine Goodman and colleagues who have been leading this development of the Equipar tool. So if you're interested, do just Google Equipar LSHM, and it might be a useful source for you if it's not then.
Very much. Yeah. So we now are going to turn to our first speaker from Latin America, who is Everton Silva from Brazil, University of Brazil. So Everton's the talk about research that's not funded by NIHR, is that right? No. But it's policy relevant, it means it's significant health economics. It's kind of a flavor of things that are happening in other parts of the world. And we can encourage Everton to apply for the next time.
So thank you for inviting me to be here and share our results from this project. That's Equipemark project that started in 2018. And this is an international cooperation with many universities in Brazil and in the UK, especially the London School of Hygiene and Tropical Medicine. And what they try to do here is some measure of impact of this research, impact on scientific evidence, what you add to the literature in this field, knowledge translation, and also research collaboration, international collaboration. I try to remove this animation here. You evaluate a program, a P4P program in Brazil, that is the PMAC, that started in 2011 and ended in 2019. And this is a little bit different from the implementation in other countries because the Ministry of Health provide new funding to primary health care and based on the performance of family health team. Family health team is a main strategy in primary health care in Brazil that is composed by a doctor, nurse assistant, and community health agents that live in the community where they are working. But the Ministry of Health cannot directly disburse the money, the bonus, to family health teams. So they send the money to the municipality, and municipality has autonomy to decide if they disburse money to the workers or not. They also can improve the health facility with this bonus. And so you have many different ways to implement that one. You can share some part of the funds to the workers or not. And also that you try to evaluate in this project here. And PMAC is a large P4P program in Brazil. Is around 95% of the municipality participate in this program, and more than 4,000 teams, family health teams in Brazil. And that's the first thing you have conducting about the PMAC, and that the main question here is there is some inequality, socioeconomic inequality in the quality of primary health care. And the hypothesis here is that if teams that are located in a very poor area, they have a lower performance. And you can see in the first round of the PMAC here, teams that are located in a very poor area, they had a lower quality performance measured by the PMAC score that's calculated by the Ministry of Health. And over the cycles of the rounds of PMAC, this inequality almost disappeared. And then do the difference between the third round and the first one, you see that the improvement in performance was much higher in the very poor area. So this is a quite important result for a policy. You have a very equitable results. When you see geographical variation here, that is the poor area in Brazil, the north and northwest. In the first round, that is the baseline of the program, you see the red one is very low performance, and the green one, higher performance based on the mean. And you see that the difference from the third and the first round, you improve a lot in north and the northwest. That's a good result. This paper here, we analyze some features, some design features of the programs. How the main question here is the difference municipality that disburse money to the works and they do not disburse money. And when they disburse money to the workers, the bonus, PMAC bonus, and if the share of this research, if you increase this share of this research, if you get more performance. And what you have seen here, using administrative data from model of PMAC, you see that improved municipality that disburse money to the works, they got a higher performance. And this increase is associated with the size of the bonus. If you disburse more than 50% of the PMAC bonus, you will get higher performance. That is important how to implement this one and see which features can improve quality. And there's another paper here, you add, there is other PMAC features here, design, and use also frequency of the payment of the bonus, and also who was incentivized. Because you have the family health team, but you also can share this money with other health professionals in Brazil, like dietitians, like a psychologist that work together with the family health team. And what you see here, the interaction of these three design features, they improve performance. When you have a higher share of PMAC with a very high frequency of payment per month, and pay to all members of the family health team, you improve the quality. So using here cluster analysis to see this combination of PMAC features. So that's important to show to the municipality the way they implement the PMAC can result different performance. So this another paper here, you try to analyze if new money to the primary health care can improve outcomes. And you see that PMAC increase about 9% of the resource to the primary health care, and also improve utilization. Here you use the antenatal care as a proxy for that, and this more money increase the utilization of the primary health care. But unfortunately, will not decrease mortality rate. So you need to improve some mechanism how to use better work in the primary health care. Here you use the under 5 mortality and avoidable mortality rate to see this effect, and didn't find any results on that. Let's talk about knowledge translation. This project was conducted in the pandemic, so we use the webinar as a way strategy to share our results with key stakeholders. And here we will share with the researchers and also policymakers in Brazil, most from the Ministry of Health and local managers. Also have policy brief here to try to communicate better our results, and also relate the impact on research collaboration. This was great opportunity for the Brazilian university to improve international collaboration that work a lot in our evaluation in university in Brazil. And we are very proud for this collaboration, especially I want to thank you, Professor Tim, Paula Jackson, and Josephine Boyd for their wonderful work that we have together. So thank you. I would like to thank the founders and also the National Institute for Health and Care Research for some grants to be here presenting this conference. Thank you very much.
Thanks very much, interesting, really, I think, the results themselves are fascinating, I think, drawing in the issues around collaboration and the forms of collaboration, and also the impact on policy and how you reach your municipalities, I think, which is really important. So the last of the research presentations is Juan Carlos Salgado, who's going to talk, who's from the National Institute of Public Health in Mexico. He's going to talk about some work on taxation.
Hi everyone, so my name is Juan Carlos Salgado. I'm at the National Institute of Public Health in Mexico, and I mainly work on things related to policy in middle-income countries such as Mexico, South Africa, and I just start that collaboration in Chile. So today I'm going to talk about some analysis related to a cost-benefit analysis of a sugar beverage tax in Mexico. First, I want to provide a little of context. Well, in 2012, Mexico was facing a high prevalence of overweight obesity. Close to 7 out of 10 adults were either overweight or obese. There was a high contribution of sugar-sweetened beverages that is a risk factor for obesity and other diseases, with a contribution of close to 70% of the average sugar intake in the Mexican diet. So, in keeping that in mind, that important health policy, that public health issue, so there was that justified intervention of the government, given externalities related to the important economic burden related to the healthcare system, and also there was incomplete information. In order to address this public health problem, the high prevalence of overweight, obesity, and high consumption of sugar-sweetened beverages, the federal Mexican government implemented in January 2014, almost 2 years ago, the first tax in the region, in the Americas. It was the first, Mexico was among the first countries in the continent and in the world implementing a tax on sugar-sweetened beverages as a health policy. So this was a tax of 1 Mexican peso that at the moment of the implementation was close to 10% of the prices of soft drinks. And there is evidence showing that after the implementation of the tax, there was an increase in the price of sugar-sweetened beverages by 1 Mexican peso, that it was basically the amount of the tax. There were reductions in purchases ranging between 18 and 17%, and it has been shown that this tax is cost saving. So, however, there were some research gaps. So there was no research assessing the effect of the tax, of this soft tax on purchases and prices, taking into account the interaction between producers and consumers. And it is this interaction and this interplay that it is going to result in equilibrium prices and equilibrium purchases. Moreover, is this important, this evidence, because we are going to be able, when accounting for the response by consumers and producers, we are going to be able to get information in changes in consumer surplus and in changes in profit. Why is that important? By having these inputs, we are going to be able to conduct a net benefit analysis of the taxes. Basically, by comparing benefits and costs. In this case, the benefits related to the tax, it is tax revenue that is going to be money available for the government, and it's going to be health savings. If there is a reduction in the risk factor, in this case sugar, there are going to be fewer diseases related to obesity, such as diabetes and hypertension. However, there are going to be some costs. A reduction in profits among producers that produce soft drinks, and there is going to be a reduction in consumer surplus related to people who value the consumption of soft drinks. So by having this measure, the net benefit, it also can work as a benchmark against which to compare other policies. It could be other amounts of taxes, other designs of taxes, or even other food policies. So in Mexico and in other Latin American countries, we have what is called warning labels, that it is basically based on the nutrient profile of the products. It could be high in sugar, high in sodium, and that's a measure in which we can compare different measures. So in the context of the sugar tax, currently the tax is 1 Mexican peso per liter. However, the recommendation by experts, it is like we should double the tax. And this is a way to by having this measure, this net benefit is a way to compare the performance of different policies in Mexico. So, well, today I'm going to present results related to two different studies that we have conducted. The first one, it is to estimate the tax effect on purchases, prices, consumer surplus, producer profit, and tax revenue for the existing tax, the 1 Mexican peso tax, and for alternative taxes, a 2 Mexican peso tax and a 3 Mexican peso tax. And the second aim, it is to estimate the net benefits of these taxes in urban Mexico. So, well, it's an overview of the models. For the first aim, we use a structural model of demand and supply. Basically, by having this model, we can model how consumers and producers respond to the tax. In the case of consumers, is they value some products characteristics, and once there is this shock that it is the tax implementation, they try to maximize utility. In the case of producers, they try to maximize profit, and it's the interaction between these decisions that it is going to result in changes in consumer surplus, in changes in profit, changes in prices, and all the other outcomes. And for the second aim, the cost-benefit analysis is going to be from the perspective of the government, producer, and consumer. By having these three stakeholders, we are going to be able to see from a societal perspective how the tax performs. And for this one, it's an epidemiological model for a closed cohort that basically we simulate at the moment of the different policies, at the moment of the policy implementation, and then we project what is going to happen. In all these cases, we are going to simulate what the outcome would be in the absence of the policy. That would be our counterfactual. So I want to provide a little of intuition behind an EPI model. So first, the main important input for the EPI model is a reduction in purchase that you can see first in the red square, and that's coming from the structure. It's an estimate from our structural model. Then we are going to transform that reduction in purchases into reduction in energy intake, that it is going to generate a reduction in body weight. And this is important because the body weight, it is going to change the body mass index, that it is the risk factor for a set of different diseases that we are going to model. Diabetes, hypertension, heart disease, strokes, a set of cancers, and other stuff. We are going to translate that into money using three main inputs. Savings for the government in terms of fewer diseases, so there are going to be some savings in terms of the healthcare system. Value of statistical life, like this is a philosophical topic, like basically is related to how people value reductions in mortality, and savings for caregivers, because by having fewer diseases, some people are going to have more time to do other stuff rather than take care of people who are facing a disease related to obesity. So, and from the structural model, we are going to have reductions in consumer surplus and reductions in profit, and we are also going to have information in tax revenue. So by putting all this information together, we are going to have the cost, reductions in cost benefit and in profit, and the benefit, tax revenue and savings for different stakeholders. So by putting together all these benefits and costs, we are going to be able to estimate the net benefit of the SSD tax. That here, because this is a cost benefit analysis, everything is in terms of money. So now I want to present estimates of our structural model, that it is like to see how consumers and producers respond to the tax. Well, let me go to the different examples, to the different results. First, we have the tax effect, the tax of sugars and beverages, the effect on prices. So first, we have the different amounts: 1 Mexican peso, 2 Mexican pesos, 3 Mexican pesos, and in the last column, the third column, we have compared to no tax, that it would be a counterfactual. We can see in general, like there was a tax overshifting, because the price increases is like higher than the amount of the tax. For example, when the tax is 1 Mexican peso, the price increase was close to 1.2 Mexican peso. So then we are going to show results in terms of the tax effect on purchases for sugar and beverages. For the 1 Mexican peso tax, we found a reduction by 19%. In the case of the 3 Mexican tax, we found a reduction by close to 47%. Here is important to highlight that the effect of the policy, it has a declining rate. So if you double the tax, you don't double the effect. So that's what we get from the model. And finally, we have the results in terms of the reductions in consumer surplus. That is a consumer surplus and profit that, as you know, in economics is a welfare measure. So we have, like, for the case of the existing tax, per each Mexican peso that is collected as tax revenue, there is a reduction in consumer surplus and profit close to 1.5. And that comparison is close to 1.9 in the case of the 3 Mexican pesos. So by having all this information, we are able to conduct the cost benefit analysis. So, and here is the result. So basically, some main information. Everything below the dotted horizontal line, it is when the costs are larger than the benefits. Anything above is when the benefits are larger than the costs. So for the existing tax, this red line shows that it is going to take, during the first 6 years, the costs are going to be larger than the benefits, and we are going to reach the break-even point close to 6 years after the tax implementation. Then, if we double the tax, and we are projecting this like at the moment of the implementation up to 35 years after the implementation. So then when we double the tax, we see higher net benefits, but it's going to take longer to reach the break-even point. And finally, when the tax is 2 Mexican pesos, it is going to take close to 8 years to reach the break-even point, but the benefits are slightly larger. If we project the benefits of through all the life of the cohort, we see like the result as expected. The net benefits are going to be flat. So well, and this is briefly when we analyze by different stakeholders. In this case, it's for the government. The main benefits are going to be in the first column. It is healthcare savings and tax revenue. Then, well, we have the different taxes and the different times after the tax implementation. Then we have the case of the consumer surplus. First, VSL stands for the value of statistical life. And the two main, during the first years, during the 10 first years, in the case, for example, of the 1 Mexican peso tax, those are going to be larger because of the reduction in consumer surplus compared to the benefits for consumers. But over time, the benefits are going to be larger. And finally, for producers, they are going to be losing money. Even though I didn't mention this, in this model, we account for tax and untaxed products, so that there is going to be a trade-off, because most of the times producers sell both, let's say water, plain water, and soft drinks. So, but it's not enough to, even the substitution effect is not enough to compensate for the initial reduction in profit. Well, the conclusion, we saw like there was a price increase slightly higher than the tax amount. We see like under the existing tax, we found a reduction by 19%. If the tax is 3 times larger, the reduction is going to be close to 50%. It's important to highlight that it is a declining rate. And in terms of the net benefits, we found initially like the costs are going to be larger than the benefits. However, over time, we expect as a society, societal gains, because benefits tend to be larger than the cost over time. However, it is going to be, even though at the societal level everyone wins, there are going to be differential economic effects depending on the stakeholder. And there is this other open question, like what is going to happen if Mexico adopts a different tax? So, and with our structural model, we were able to see like if we move from a volumetric tax, that it is the same. If the beverage has added polish, has added sugar, the tax rate is going to be the same. However, some years ago, South Africa and the UK implemented sugar density taxes, and we were able to compare the performance of those taxes in Mexico, keeping in mind preferences in Mexico, the structure of the market. And we saw like promising results, like in Mexico, move from a volumetric tax to a sugar density tax, mainly because of reformulation. Thank you so much.
Right, thanks so much for the progress. Again, another really interesting type of analysis, and the sort of thing that it would be great to see coming through into the NIHR program. So I'm now really pleased to introduce our last speaker, who is Mark Fletcher, who works in the South African Treasury. we kind of think of him as the health guy in Treasury. So he's going to talk a little bit about the sorts of about decision making about health in Treasury and the sorts of economic evidence that are influential in those sorts of things. So Mark, over to you. Just say, well, he's coming out. So Mark was a commissioner in our Lancet Global Health Commission on primary healthcare financing. That's a real delight. Thank you.
Thank you very much, Tara, and good morning to everybody. And really kind of surprised to see so many people out on a Sunday morning in a really rainy environment. Welcome to Cape Town. I'm just going to speak very briefly and more kind of generally, rather than giving a lot of specific examples, which I might do in a more perhaps specific topic. But maybe just start perhaps with a little bit of a kind of a caution or joke. You know, coming from the Ministry of Finance, we often get told not to talk about health policy, to stay clear of health policy and to stay in our lane. So, you know, that's fine from a Ministry of Finance point of view, but what we find is whenever the decisions coming out of health policies are significant, they tend to have budget implications. And so that, you know, they often make their way fairly rapidly back into the health economic space. And then there's a lot of, you know, questions then that the Treasury then needs to ask about the way that the policy work was done and, you know, the various analyses that have been done that have informed that particular policy. So health economics research is really, in our experience, vital to inform budgets. I was saying yesterday, and I hope Dr. Mills doesn't mind if I repeat myself, but you know, we in the Treasury we work with a lot of different budget programs. So you work with the HIV program or the cardiology program or the mental health program, and many of the health programs or many of parts of the service, in our experience, have not made budget bids to us in a decade or more, and it's often because of the in a sense the lack of economic capacity in those programs. In many low and middle income countries, people who come into government, into the health departments, are coming from a health background. They don't necessarily speak the language of ministries of finance, of how to construct an economic argument or budget bid. Or necessarily even know how to work with those economic researchers to develop the agendas which would inform such budget bids. So, you know, in our experience, the economic research and analysis necessary to inform a budget bid is very important, and it depends also on the ability of health programs to work to bring in economists and relevant researchers to do the kind of work which can inform these budget bids. All right, I think it will also be very obvious to colleagues here that research around health technology assessment, around economic evaluation is critical to the work of programs, selection of new interventions in health departments, and similarly to the support from ministries of finance in supporting the introduction of new interventions. There's some colleagues in the room here who have done very, very extensive work in health technology assessment and given global leadership in that area. In our Treasury, we have at times been quite frustrated because we found that a lot of the work on health technology assessment has fallen on the Treasury to assess new interventions. We've been, you know, we get board policy, and then the Treasury gets asked often politically to then assess that intervention to an extent where we've almost got to a point where we've kind of said we're not going to do that anymore because the sector needs to develop its own health technology agencies, its own health technology capacity, and to do this work. I mean, it's clear this kind of work is the bread and butter of selection of new interventions in the sector.
of course, we often get asked to support interventions that are not necessarily that cost effective. Politicians also often want everything to be supported, and so that kind of research is clearly really important. But also in a sense, I guess for this kind of audience, fairly obvious. Then perhaps just to say that going beyond the individual interventions, increasingly, I think the treasuries also need support from the researchers who are supporting their health counterparts, or even the ministries of finance, around more complex multi-sectoral interventions. I mean, working in the Ministry of Finance, I, for example, head a section that heads health and social services, but I have colleagues who deal with, for example, the water budget or the roads budget or the communications budget, and all of those compete in the national budget process. And they often have also cross-sectoral implications. So spending in a particular sector has spin-off implications, for example, in another sector. So the costs may be incurred in a particular sector, but the benefits are shared in another sector. And I found it extraordinarily difficult working in the Ministry of Finance to kind of develop a kind of common methodology for assessing funding decisions across sectors. And I think increasingly, many of the health problems we face in the world today come from problems which require interventions in multiple sectors. And so some kind of guidance in the research you support pertaining to those would be helpful. In the Southern context, for example, there's a simple example. We have clearly a lot of problems around energy at the moment, or a lot of problems around water. We had a big outbreak of cholera in Hammanskraal area of outside Pretoria. There'd been a lot of concerns around the Rooiwal sewage treatment plants in the Pretoria area. And so there are choices between, often one's criticized perhaps for not putting sufficient funding into the health budget, but unless that the 3 billion investment in the Rooiwal sewage treatment plant is done, the cholera epidemic is going to continue. So those are complex kind of budgetary decisions. How does one weigh up these kinds of issues? Then, of course, a lot of countries are going through health financing reforms, and there's a lot of need for research support. Including our country is one of those, which is going through difficult financing transitions, and so issues pertaining to revenue raising and pooling and strategic purchasing, that kind of support from funding from research organizations, that kind of and leading researchers can be really useful. I'm sorry, I missed some of the earlier presentations, but I really enjoyed this last presentation on health taxes, which are, of course, a very relevant area of collaboration between health sector and the finance sector. South Africa does have a sugar sweetened beverage tax report at the health promotion level, a levy which we are reviewing and reconsidering. And the role of researchers played a key role in that revenue arrangement, and is clearly a really important public health intervention. Just lastly, I think many ministries of finance are going through a very difficult period at present in the post-COVID environment. The global economic recession after COVID has put huge pressure on budgets. Many countries in Africa and elsewhere have gone into quite serious debt crises, and are having to make very difficult spending decisions. And good research to inform some of those spending decisions in this post-COVID period. The World Bank double shock, double recovery paper, I think the third version of that paper was released about 2 weeks back, and it's shown some countries after rapid spending increases have come back to baseline. But what I didn't see enough in that paper is perhaps a fuller description of the large number of countries which have gone significantly below the baseline. And South Africa is actually one of those countries which is currently substantially at risk, going through a long, difficult economic period after COVID. That raises many difficult spending decisions, which good research can help to support those kinds of spending choices. So thank you for this.
Wow, thank you so much. I think the link to Paul's earlier presentation about capacity strengthening in government departments and thinking about how we can help through our research programs to help develop the capacity to do more of that analysis in the health departments to make a better case to finance, I think is a really important element. As we think about both capacity strengthening and impact, I think thinking about how do we draw Ministry of Health colleagues into our research is probably a really good question for us to debate. So I realize I haven't given you any chance to ask questions. Actually, we're sufficiently far behind in our schedule that I'm going to not let you. But we'll ask you, I will say at the very end, we'll spend a few minutes if you have questions about the NIHR program itself. We'll come back to that. So save those up. What I'd like to do now is to get you into some small groups to help me. So I've outlined three themes here. So one is about methods. So what areas of methodological development and how can NIHR fund methodological development as part of its global health research program? The second is about capacity strengthening. So what are some of the key strength and capacity gaps in global health economics research, and what sorts of mechanisms might the research program develop to help to address those? And then finally, policy impact. So what types of health economics research are the most impactful or likely to influence policy? And what are the sorts of mechanisms through which NIHR can encourage or incentivize research that really takes on these impact agendas? And I'll tell you, and one of the reasons behind that is that part of my job is to make the case to the British government for the value of global health research. So the better we can do that, the more likely we are to continue to be able to fund an expanding, exciting program of research. So this is me asking for your help, and then it suggests that you get into three groups around, kind of circled around each of the flip charts. So maybe that one there could be on methodology up in the front, this one in the back on capacity strengthening, and this one here, we will move it around here on policy. Now I could ask you to kind of cluster around those according to your interests. And then maybe we've probably got 20, 25 minutes for some group discussion. Come up with some really practical suggestions to me. My colleagues from NIHR, Francesca and Jessica, and I will split ourselves amongst the group, help to take some notes. But could I ask each group to come back and report back? So nominate, please, a rapporteur who can come and give us a quick summary of your discussions at the end of the session. So we'll come back at 11:45, and then I'll make sure that we do have minutes at the end to answer questions about it. Okay. So methods, capacity, impact. So, these are really great questions. So a few things we want to pack in. So one is report backs from each group. We do have people packed in, so you don't need to be totally comprehensive, but you capture the main points in your report back. Then I'm also going to ask Anne, who else chairs the health systems, health policy and system research panel of the Global Health Research Program. And she has some thoughts about what sorts of proposals are more likely to succeed. We'll get a bit of insights from our chair. And then we'll have a few minutes for any more questions that if I'm not able to answer them because I'm really new to the program, maybe Francesca or Jessica will be able to answer. So let's start with the report backs. Let's start here.
Right, so the first question was, what types of health economics research are most likely to policy? So we discussed nudging, so kind of behavioral economics, the translation of research in low income settings, which are usually resource constrained, to high income settings. disease prioritization through its burden, the integration of health networks, so things like telehealth, understanding decision-making environments, I don't know, it's the thing, but AI and big data, health-seeking behavior, okay. So then the other question was more to do with how can NIHR encourage and incentivize research that leads to public policy practice. So we were talking about understanding what research does policymakers want. So anything that is directly commissioned by them, and any kind of rapid response. So understanding what are the kind of research priorities at any given time and having rapid response programs. We were also thinking about scoping with policymakers to have direct calls. And then we're saying that NIHR could have funds for priming for research proposal, things like pilot studies, evaluation. And we were also saying about requirements within these proposals, for instance, to have policymakers in our steering groups. So not coming towards the end of the call, but from the very beginning, engage with these policymakers. We're talking about capacity strengthening for using students. It's a great resource to see students be students. We were also talking about having more comparative studies. So what has been done, say, in South Africa, in Chile, in Mexico, that can be applied to other settings, and organizing sessions on policies. So Francesca mentioned that this is some of this is kind of already done through the NIHR Academy, but this comes post-funding. So we're thinking about pre-funding for people that are looking to apply, understanding how does the policy making process works. For us as researchers, understanding how the work. And then as well, towards the end of a grant, having impact acceleration funds help us with this. International collaboration fund. Well, helping us with communication skills. Often for impact, you need to be a good communicator. So how to have a more research that may be very complex, but knowing how to simplify it for better communication. Which is obviously a tension with publications, because sometimes the things that get published are a bit more complex. And we were saying that at the moment, economic evaluations are very well funded. That's bread and butter, but things that are less well funded are things like some more macro things like health systems research, governance in health. And yeah, so that's kind of what we were saying. Newton Fund collaboration, partners, in extensions of collaboration. So we have a really good international partner if there could be any funds to extend that collaboration. I think I've covered all of that.
We'll go around to the capacity raises. Sarah is going to report back here.
So we focused on capacity strengthening, and the first question we had to address was what the capacity gaps in global health economics research. So we thought it would be helpful to break down the various actors that are involved in actually doing this. So we first started out with researchers, and we identified that the gaps that exist are wide ranging. So there's things like health economics researchers themselves, and how do we upskill them to understand various health economic techniques. and how to apply them to the local context that they're working in, quantitative researchers and trialists, how to upskill them as well, and also looking at the north-south divide, so what capacity building can we do to make sure that the skills that are available in all settings are accessible. We also look for policymakers, so not just national policymakers, UK policymakers, because that's what NIHR is based, but also international policymakers and how we work together to ensure maximum impact. Funders themselves, not just NIHR, but also working together with other funders, whether it's other funders in the UK or other places globally, and how we can ensure that the priorities are synergized and working together to ensure that a big aim is reached well. And also community groups, and I'm with some groups as well. So in my experience of global health research, global health economics research, there tends to be a large gap when it comes to patient and public engagement and involvement. How do we adequately engage citizen groups to make sure that their concerns and their voices are heard? So that's a really key gap that we need to address. And how do we actually build those gaps? And there's a couple of things that we discussed. So looking at how we can implement decision tools or decision-making tools, whether it's an online tool or an engagement tool that we can work with the person and together as part of a larger group going from various institutions based in the UK and globally. Open access. So open access tends to be an interesting term. So as part of NIHR guidance, you are supposed to make sure that all the publications that you produce as a result of the grant is open access, and NIHR does provide funding to do that. But for other things like maybe data sets or other sorts of knowledge that is generated as part of the grant, that might be a little bit of a gray area. So, more maybe clear guidance on how that is published would be helpful. Soft skills development, so not just kind of the hard skills, such as, the box and health economics, but also how to manage grants, stakeholder engagement, how to present, things like that would be great to be funded so that we can learn how to best make an impact research and how to communicate our findings in the best way possible. Training policy colleagues. So at the moment, the NIHR Academy does provide, I guess, upskilling opportunities and engagement opportunities for researchers, but I'm not quite sure how much they engage with policy colleagues. So widening access to engage with policy colleagues, and actually also program like this would be a really helpful thing to do, I think. So that they can work together better. Aligning capacity building activities with other initiatives, so other programs such as Spark, the Joint Learning Network would be helpful. Fellowships for early to mid-career professionals. So for other NIHR grants that aren't global health related, there tends to be a clear pathway starting from doctoral all the way to professorships where they provide funding for whatever stage of your career you're at. But for global health, it's a little bit, there's not as much engagement for early to mid-career professionals. So I think more fellowships that can provide that would be helpful. In addition to PhD funding, at the moment there's no PhD funding for global health research if you're a UK-based researcher, so that would be helpful. And then also we have a conversation about interschool collaboration and synergies. So at the moment, so I'm speaking personally, I do run in the NIHR Global Health Grant. I do think we try and do a good job of engaging as actively as possible, but we recognize that a lot of the times if you are part of an NIHR grant, the UK institution, the lead institution, naturally sometimes it can be a bit of a north-south divide. So how we can make sure that maybe the contracts, there can be some sort of, I don't know, condition or funding requirement that allows or kind of incentivizes the lead institution to engage more particularly with global south researchers. I think it would be really helpful. And maybe even turn it to a scoring system. One of our colleagues suggested that. Synergies between other NIHR programs. So, there's a wide range of other NIHR programs, not just the global health, within the global health program itself, but also widely with the NIHR institutions. So how can we work together with them to learn skills or other helpful pointers that they've learned about their grant progress. And then obviously translating our research into impact. There's no point in our research if we're not engaging with our institutions about our research into policy. So looking at budget impact considerations, working with institutions like national treasuries, and also gaining skills and knowledge translations so that we're better able to actually communicate our research as best as possible. And then lastly, cost-cutting measures. So, we're all autonomous, we work in this area, but there's other, themes such as climate change, macroeconomics, and, WASH, other things that are really important and link really well with what we do. So being able to work together with other professionals and learn from them what their needs are and how we can apply our skills to be able to best meet their needs and their policy considerations, I think is really important as well. So yeah, I think that's everything. Great, thank you.
Very much, Sarah. Okay, the last bit is over here. This one we don't remember it. So keep reporting back. Thank you. This, but we were talking about methodological research into the local health programme, and I'm going to take the first and the last questions together really. But it's just that we felt that in terms of methodological research, there was some suggestions about looking at simulation, particularly looking at areas where we haven't got much data or there's a lack of data, comprehensive data, and what do we do? How do we manage that within methodological research? What are the methods that we could develop to account for that, either generating more data, better data, linked data, how do we link onto existing systems like routine data. The other thing was around looking at methodological perceptions around investment and disinvestment. So looking at the prioritization of what we fund, what the kind of perspective of what do we not fund, methodology. There was some talk around how we can actually cross learning between the north and south in terms of actually methodological approaches that have to be adapted within the kind of global south to do health economic research. Actually, are there things that the north can learn from the work that's going on there that we can actually use to improve the method, particularly around economic evaluation and analysis in other contexts? So what can we learn from those as well as vice versa? And also looking at looking at the developing validation of quality of life tools into context. Countries actually doing some original research around looking at the cultural context and what those being implemented. We talked about as well more rigorous impact evaluation methods, and there's some quite strong views on what those need to be. In terms of the incentivization, we similar to the other two groups actually thought that there needs to be kind of potential greater linkage between the Global Health Research Programme and other NIHR streams. But actually there's probably a lot of methodological research going on in those other streams that would benefit from having a international partner from the global south, but actually the incentive found up in those streams needed are adequately fund those within that. And actually, if you do want to fund that, it's a way that you can cross fertilize between global research programs and the other streams like that. More about the research, in fact, the kind of the decision rules in prospectus analysis with regards to obviously the thresholds for funding, so methodological research around that, and methodological research around the distribution of impact of policies, and that would benefit forward in terms of and more in terms of looking at disaggregation of who sees where the cost burden is with the benefits and breaking the from that as well. I think that was about it. Thanks very much, Angela. So three really rich discussions. I know that Francesca is running away crazy to make a list of things that we can do, which is great. And I do hope that on the basis of all of these ideas here, you will begin to see some changes at the margins that's already really successful in all this. So to expand opportunities for working. So we'll take these away and then you'll hear some of them back at you in the future. So two last things. So I want to talk about your perspective as a panel chair on what makes health economics proposals more or less likely to succeed at panel. So do that for a few minutes and then I'll come back and we'll look at this.
Thanks, Karen. Two very quick points. So I've been chairing the Research Policy and Research Council when it was set up, which was years ago, I think now. And two things have come out to me, both from that, from the Medical Research Council side of the panel, which I've also been on. And the key one is that there's an emphasis on both the research and on the policy impact. But we're all very enthusiastic about policy impact, and that's really important. But don't forget that this is a research funding stream. It's NIHR, the National Institute for Health Research. So the scientific excellence and the scientific questions must be there. And there must be an ability of the research to produce research knowledge, i.e. knowledge that is to some degree generalizable. I mean, we know that generalizability can be a huge question in health systems research, but nonetheless, this is a research funding stream which is required to have policy impact. And just make sure that you balance that, because I've seen proposals that are at both extremes. One that are only about research with no links to a policy question, policy need, policy demand. And then at the other extreme, proposals that are much more like a development project, building institutions or programs or organizations within a country, but with no real sense as to what extent does that provide lessons for the rest of the world. So get that balance between scientific excellence, scientific research excellence, and policy. The second point is the really challenging one which Tim raised about the fairness and equitable partnerships. And in general, funding panels don't have explicit criteria. NIHR doesn't say that it's equitable if the budget distribution is this, but Tim's quite right that these panels, and I would emphasize that the panels, particularly given the fact that quite a lot of the panel discussion is now online, they're far more equitable than they used to be. In that, there may well be some of you in the room on NIHR or LC panels. And so there is an understanding in the panels as to what is there. And one of the things I would say is if, for example, you're putting in an economic evaluation project and you have a cost component, most countries have capacity to do the cost analysis. You don't need to have a UK economist do the cost analysis. And that's just a small example of where I'm pretty sure a panel, if you put in an application, having a costing done by a UK researcher on the grounds that there's no local capacity, that would not be looked on favorably. So that's just a sort of insight into what it means in an application to have an equitable partnership. Thank you.
Thanks very much. So let's take, if you've got time to start, I don't think any sessions, everyone's banging on the door, so we've got a few minutes in the room, I think. Or if you feel you have to go to I just wanted to give you a chance to ask any questions of myself, Francesca and Jessica, who are here from NIHR, or it's about that one officer comments. Oh.
Not questions, just give something a little bit more emphasis, which I think is really important. And was reset background my role. So it's something that's in raised about the requirements which are placed by UK funders on institutions in the South. We have a terrible issue where we're required to get, because I have this wrong, professional indemnity insurance in countries where it doesn't exist, and it feels like a lot more can be done just to make it institutions in the South. Sorry, the program managers who experience in the South. They do more than that. They will be very appreciated.
Okay, thanks for that. And one of the things that I will try to spend a bit of time uncovering is how do we run these programs in NIHR and why? And now that it's kind of a learning thing, understanding how. So is it the case that all of the restrictions and controls remain necessary? I think we I don't know. So do you know who the other these organisations or countries are that fund the same sort of research that you're looking to fund? Because you mentioned about wanting more from South America, because I've not got many of those. I was wondering, is there a lot of funding from North America that comes to South America? Or like, do you know where you are on the global? I personally don't. I'm going to ask Jessica whether she knows where we are. That's fine, I can help you with that. So,
we know if you're question specific about the Americas, we know that the National Institute of Health Research, but from the US, has a strong footprint in that region. There are also partners from Canada that we work with as well, and we understand there's a strong field of funders on that area. What we know as well from our portfolio is that the leading region that is successful in our funding stream is Africa, then is the Indo-Pacific area, and then the third is Latin. I think actually the fourth is Latin. So that's one of the reasons we encourage the Latin American community to be present today, but that doesn't restrict UK institutions to also partner with Latin America. I hope that answers your question.
It's just about adding value, because what we want to presumably put the money where other people can't.
Yes, well, I guess on that point, we know that the official development assistance budget, which is the funding that we provide, should benefit those that need it the most. So I guess, yeah, we need to go.
Yeah, that's really important, and we try Optimising to be quite data-driven approach, looking at sort of what research already exists to try and find sort of research gaps there. But we tend to do that, to be honest, in a very sort of data-heavy way, rather than engaging the sort of consortia with national funders. Definitely something Cara will be thinking about as we go forward in through this thing. I think quite data-heavy.
Just one small added. I'll say that while geographically there's some kind of areas for that word, I believe in NIHR stands out as emphasis for something. A lot of areas, unfortunately, while broad, it doesn't focus. It's very silent and very focused on to some degree. Very, very management. This is where I think is.
Yeah, thanks. I think that's really interesting. So I think if you think about the health system side and the HPSR side, where the UK originally had something called the Health Systems Research Initiative, and as you remember, that was FCDO and Welcome and the SRC and MRC that's disappeared. So NIHR for health systems research is really taking over that space. There's not much really like it in the rest of the world. There's the advantage from health policy system research, but more than institutions are mostly knowledgeable already. So it is pretty unique. And the EU as well. So Horizon funding also interesting. It is unique because recognized.
Hi, thank you. Thank you everyone for the thoughts. Really very nice. I would like to know from the panel, the director, how possible it is to have proposals that are multidisciplinary. So for instance, I'm working in a polytechnic university and we have different research labs. One of them are conducting in-field treatment of banana plantations, but they're just limited to a small communities, small size communities. Then we have the Research of Economic Center, in which I am, in which I'm also doing papers about these banana pollutions and how it affects infant health. But we need like this interconnection, which I'm pushing way very strongly. But still there is this constraint about budgeting. So for instance, many bodies who have been approaching, they are like, okay, your proposal is so broad because it's so multidisciplinary that we don't know you are going to target the 100% of each of those stages. But the things that we do can. So I would like to know if in your vision, this is like a problem, like having a multidisciplinary proposal, or is actually something attractive?
Thanks.
I wanted to speak because I've seen a couple of proposals recently, both NIHR and Medical Research Council, which are cross-sectoral. And in general, panels really like that. But it's, on reflection, I think it's quite a challenge to translate that, because you have to recognize that these are health panels. Ultimately, they want to improve health. But, you know, the panel accepts readily that there are different ways of improving health, but somehow the proposals I've seen recently have not been sufficiently convincing in their research questions and methods. So I would strongly encourage that, as long as it's within the remit of a particular course, but to think carefully about how you work across sectors or across disciplines. But in the UK, there's an extremely strong emphasis on multidisciplinary, cross-disciplinary research, which is reflected in all our research funding bodies. So really important.
Yeah. So I think there's something cross-sectoral and cross-disciplinary, right? So that the cross-sectoral, I think, will work in tight enough to help. The multidisciplinary is just the bread and butter of research, really. I've never seen a proposal as the same multidisciplinary, even in health economics one tends to vary.
I recommend looking at Africa, and then NIHR funded projects that examples of that on the website. The website is rather rich in the sense of listing all of the things that help with benefits. I would encourage you to have a really good trawl to get a sense of the sorts of things that they
It's just thinking about the points that you make about incentivization, and I think about how structurally the Global Health Research Programme is different to other research programmes and within NIHR, and how it might be different than how the Global Health Research Programme sets up and monitors research maybe differently, or maybe needs to be different to other NIHR programmes. Part of it might be about allowing a little bit more flexibility in terms of allowing innovation to come into kind of methods, and allowing kind of a space within the first couple of years of research for that to develop, so that it's not set out in black and white right from the outset, but that there are appropriate monitoring strategies within the research to ensure that people just don't go down a rabbit hole, and that they are actually going to deliver on what they said they're going to deliver. But the same might be said about the front end, particularly the question now, the point earlier about whether actually NIHR might fund the setup phases of research, which they don't obviously ordinarily potentially fund, but to ensure that capacity and administrative capacity, particularly in other countries, is there and funded, and whilst the project administratively is getting going.
Is on the latter, it was an HSR stream, was it the establishment of partnerships?
That's awards. It's called the development awards.
Development awards, which were a maximum of about £100,000, and they were very popular and very successful in terms of funding. Some might be extended.
On the new right call, we also have what we call PPDAs. Now I can't remember what the people for. One of them is partnerships, and that also allows you during the application stage to have some funding to develop your application further with partners. So if you're looking at the right call, have a look at that.
It's still important in terms of the development of a partnership early on, is to get a listing of the development where things get really big. I just say thank you very much for contributing in all of the different ways that you've had. It's great to hear about So the projects and those projects that are funded by NIHR and not, but you hear these kind of themes of capacity and partnership and impact. And then you get lots and lots of suggestions going forward. So I'm still very much in a listening phase, but it's a very exciting time, I think, to be part of this program. As you really have a chance to work on all of you about facing and thank you very much.